Well, welcome to the plenary session of the 69th Annual Utah History Conference. My name is Jedediah Rogers with the Utah State Historical Society. Just a reminder that this session, along with our other sessions, is being recorded and will be made available on our YouTube channel. You can access the full programming from this week, as well as pre-recorded sessions that we have on our YouTube channel. You can access all of that through our websites at history.utah.gov or ushs.utah.gov. This morning's session will run until 11:30 a.m. Any questions or comments for our panelists can be entered in the Q&A box at the bottom of your Zoom screens. And we encourage anyone and everyone to submit questions. For those of you tuning in via Facebook Live, we're also monitoring questions that come in from there. So thank you. I can move my screen. Oh, there it is. A big thank you to our sponsors this year of our conference, the Utah Division of Arts and Museums, Utah Humanities, Utah Westerners, and of course, the Utah Department of Cultural and Community Engagement. So this plenary session, Perspectives on Human Wellness, Public Health, History, Education, Policy, and Practice, is not technically our first session of the conference, but we think it provides a good base for the rest of the conference in understanding the theme, public health and the common good. The theme was born of the pressing circumstances that we each find ourselves in, and we want to have conversations that speak to or inform societal issues that we face. Underpinning our conference theme in this plenary discussion, from my perspective, is the idea that any attention to public health requires some commitment to thinking about a common good or shared responsibility. Also, the idea that public health is not only a medical or policy issue, but a historical one as well. And by the same token, any discussion of the history of health and wellness is bound to inform healthcare policy and medical processes. So when thinking about unequal access and outcomes of health, as I know our panelists will discuss, I think it's helpful to understand the complexities of these inequalities, in part through the systems and processes and ways of thinking that go back generations. These past 2 years, we've heard and experienced for ourselves story after heartbreaking story. And so it seems appropriate now of all times for us to talk about something so basic and fundamental, so intimate and personal, and yet also so public as health. What I appreciate about this plenary discussion that we're going to have is that rather than just a conversation between historians, here we'll have interaction between historians and public health educators and scholars with the aim to think broadly about health and wellness, past and present. And Ben Cater has done the heavy lifting to organize and conceptualize this plenary. And I should say that any attention to the history of public health in Utah, especially during the early 20th century, relies on the work that Ben has done. Dr. Ben Cater is Associate Professor of History, Dean of General Education, and the Director of the Honors Program at Point Loma Nazarene University. And I will turn it over to him now to introduce the panelists and to launch the conversation. Ben.
Thanks, Jed. Well, welcome, and it's good to have you join us today for this conversation. So yes, my PhD is in history, and I received it from the University of Utah. My interest in this discussion really is related to my interest in my research. I wrote my dissertation really on the origins and the evolution and the social effects of the health industry in the early 20th century, particularly in Salt Lake City. Really a little bit about my background. My dad was a professor of medicine at UCI School of Medicine for many years, and then he was a consultant for Newt Gingrich in the 1990s when Newt Gingrich, the Speaker of the House, was trying to propose an alternative medical reform plan to counter Hillary Clinton's, then the First Lady. And then when I was writing my dissertation, it was in the context of Obamacare and proposals for it and ultimately its passage. And now I find myself in mid-career in the midst of a pandemic, which I ended up writing partly about in my dissertation. So I guess my sort of childhood, but also my professional years have been surrounded by these discussions about public health and its significance and medicine and medical practice. I'd like the panelists to say a few words about themselves. So I'm going to turn it over to Len. Len, why don't you go ahead and tell the audience a little bit about yourself?
Hi, thank you so much, Ben. I am Len Novilla. I'm an associate professor at Brigham Young University, and I am also a member of Utah's Multicultural Commission, as well as Utah's Multicultural Subcommittee of the COVID-19 Task Force. I'm also an executive committee member for the Thrasher Research Fund, and also a member of the Utah Poison Control Center. I have been in public health almost all of my professional life, and I am so grateful to be here. My research focuses on the social determinants of health, as well as on the family as a sustaining framework for integrating public health and primary care to attain health equity, as well as improve population health. Thanks, Ben.
You bet. Paul, do you want to go ahead and introduce yourself?
Yeah, thank you. It's a pleasure to be on this panel, and especially a pleasure to be on a panel organized by one of my former students. I'm really proud of Ben and his scholarly trajectory and the research that has brought this together. I'm Paul Reeve. I'm Simmons Chair of Mormon Studies at the University of Utah. I teach courses on Utah history, history of the U.S. West, as well as Mormon history. And obviously, those topics bring up issues of concerns about public health in historical settings. So I think that's my role on this panel, is to share some of those historical perspectives.
Thank you, Paul. Monique.
Hi, everybody. It's great to be here. I have to say that as a healthcare clinician, this was my first opportunity to speak at a historical conference, so it's very exciting and unique for me. So I come from Point Loma Nazarene University, along with Ben in San Diego. My clinical background, I'm a psychiatric nurse practitioner. I'm a nurse in public health. My title, I guess, is an associate professor of nursing and associate dean of the traditional undergraduate program for nursing. My research interests span mental health and public health, looking at things such as increasing access to therapeutic interventions for children with anxiety, looking at sexual health education at a private college campus. I'm currently looking at mental health needs and services coming through the pandemic on our college campus. And then most recently have been thrown into the deep end as part of our COVID response team here at the university. And so have gotten to do a lot of real-time public health recently.
Thank you. And Gretchen.
Hi. Excuse me. I'm Gretchen Case. I'm at the University of Utah. I am the director for the Center for Health, Ethics, Arts, and Humanities at the University of Utah. I'm also an associate professor in the School of Medicine. I am an arts and humanities scholar in a health sciences campus and a School of Medicine. I was trained in history, communication studies, cultural studies, and performance studies. Then I worked as a public historian, specializing in histories of science and medicine after in between, actually, some of my degrees. So I'm here to talk to you about using the humanities as part of health sciences education and why history in particular is important at this moment in time.
Mm-hmm. All right, terrific. I mean, it sounds like we have a very interdisciplinary group of folks, and makes sense since public health by definition is an interdisciplinary discipline, course of study. I look forward to this conversation today. I'm interested in hearing a variety of different perspectives, and why don't we just jump right in? The title itself, Public Health and the Common Good, is just fraught with meaning. So I would like to hear you folks comment a little bit about what does the conference title mean to you, both in the aggregate, but also the individual parts. What do we mean by public? What do we mean by health? Public health, what do we mean by the common good? Who would like to jump in first?
I'm happy to dive in, Ben.
Yeah.
For me, I think public health just is speaking about the health of the population as a whole. And for me, then, what does it mean for the intersections between public health and the common good? And I see society only as strong as the vulnerable amongst us, the most vulnerable amongst us, and therefore, common good means, how can we bring about public health, the population as a whole, in a way that brings about the most good for all of us. That includes the most vulnerable amongst us. So the intersection between those two things, I think, has been a question that society has tried to deal with for a very long time. And obviously the current situation that we're in raises these questions yet again.
Mm-hmm. Mm-hmm. Yeah.
When I look at the title, I see at least 4 words that we could spend an hour on each, right?
Yeah, right.
But I keep coming back to the idea of health, which is at the center of this. And I think that is often regarded in discussions about the common good and public health as a static idea, that we know what health is, we know what wellness is. And I think that's very different depending on context. And that's individual context, public context, historical context. And I think that's easy to forget, that when we say health, I'm already using the word we, right? And that we is not everyone agreeing on what health is. That's part of what we're seeing right now, is what people consider health. It's different than what someone else might consider health. And so asking people to work towards public health or the common good isn't actually asking them to work towards the same goal unless we've discussed what we mean.
Mm-hmm. Oh, good point.
That's a great point. The things that keep coming up for me with this topic are something that I talk a lot about with my students. If we're talking about health, which, as Gretchen said, can be defined in different ways, we also have to think about, if it's a common good, then is it a right to all of us, or is it a privilege? And I think that that's another thing we could talk forever about, but identifying how we see public health, how we, value it. Do we see it as a right or a privilege? Then is going to have a major impact on our policies and what we provide to the entire society, including the most vulnerable.
Mm-hmm.
I'll jump in next, Van, and thank you for this great question. For me, when you say public health, the meaning is already in those very words. It's the health of the public. It's population health. But I always hearken to Charles Edward Emery Winslow's classic definition of public health, which is the science and art of preventing disease, prolonging life, and also promoting both physical as well as mental health through organized community efforts. Mm-hmm. And key words to his definitions include social machinery, as well as ensuring to every individual a standard of living that will allow them the maintenance of health. And for me, the shortest definition would be that public health is the nation's health. And therefore, we're not only aiming for the common good, it is also a shared responsibility.
Mm-hmm. Well, what I'm hearing in particularly your response, Lan, and implicitly in some of your others, is this notion of who we are is tied to the state that we inhabit. In other words, there's a political dimension to us. When we talk about the common good, when we talk about public health, at least in the United States, as a shared responsibility, but really sort of a government responsibility, we have to ask ourselves, well, public health resources, who do they apply to? Who pays for them? And usually the answer to both questions is the same. It's citizens. And so citizenship, at least historically, has been tied very closely to this notion of we citizens and our health and what's good for us, generally speaking. And so just to be clear, I think what we're talking about is citizens individually, but also collectively advocating for something that is good for us and our health. But again, we have to ask, what do we mean by health? Does this include simply our physical bodies? Does this include our emotions? Does this include, our mental health, et cetera? And I'm curious, when we think of health, when you folks think of health, are you thinking about all of the above, or are you thinking it in sort of more specific, perhaps even narrow ways, like physical health or simply mental health, or are they both, or can they not be separated?
Well, the 1948 definition of health by the World Health Organization says that it's the complete state of physical, mental, and social well-being, and not merely the absence of disease or infirmity. So for me to compartmentalize health into just one aspect is to actually forget those many influences, factors, and variables that contribute to health. So for me, I see health more from a wider context, from a different set of lenses that looks into health in terms of really every facet that contribute or influences individual health.
Mm-hmm. One criticism that I've read about, that I've heard in these types of conversations, is that the very notion of common good, the very notion of public health, particularly public, is passé, simply because we inhabit right now such a culturally and politically divided nation. I guess a question that I'd like us to consider is simply this: is it possible for such singular terms to have shared meanings?
So is it possible for something like health to have a shared meaning?
Yeah, and I think what I'm getting at is not simply health, its definition, but the common good. Like, do we really all have the same hopes, dreams, and fears relative to health?
Well, no, because we're made up of individuals, but certainly there have been many, many times when people have said, but together we need to make this happen, or we do have a shared understanding. I think that's what we're in the middle of right now, is a reforming of the idea of common good. So maybe what we had before didn't hold up to this pandemic, but what we're seeing right now is a move back towards, I hope, an idea of how do we work together? What is the common good? What are our shared goals? All our goals don't have to be shared, but some of them do, if we're going to come out of this pandemic with living people, to be honest, and people who are not harmed. So I really think that's what we're in the middle of, is reconsidering, what do we mean by the common good? What does that look like in 2021 in the middle of a pandemic? It certainly doesn't look like what it looked like in the flu pandemic of 1918-19, or we would have a very different conversation going right now. So 100 years has made a difference.
Yeah, and I would just add to that while we all here recognize health and value it as a holistic way of being, I think at the very basic core, perhaps the majority of us as Americans could agree that not experiencing death, right? Not experiencing severe injury and illness is a goal of health. And I would add to that access, in the sense that I think on an individual level, each person wants to know that they can access the healthcare that they need when they need it. Now, do we recognize that we want that for everyone else? Not necessarily, but on an individual level, I think we, for the most part, could agree on that.
And actually, I'd like to jump in, and thanks, Gretchen, and thanks, Monique, for your insights. I do appreciate that. I'd like to go back to the word that you used early on, when you were asking us about the definition of public health. You said a word, interdisciplinary. So could we have a shared definition of health? Honestly, I believe so. Yeah, I think we can do that. If we are to be interdisciplinary, we need to actually have not only shared definitions, shared meanings, but also shared understanding for a collective impact. For me, one of the things that has been difficult in working in a multi-sectoral environment was that we all have our disciplinary boundaries, and we kept staying within those disciplinary bounds. When actually, if we stretch those bounds, we can find out that there are so many things, concepts that we actually hold the same, that we hold highly. And so I think there are those disciplinary jargons that limit not only our understanding, but our collaboration. I honestly think we are aiming for the same thing, whether we're in the health sector, whether we're in the housing sector, transportation sector. I do think that we could actually aim for a shared definition of health.
Mhm. Yeah, so I mean, it sounds like the answer is incredibly complicated. The question being, are these terms passe? Can in such a divided nation, a nation of individuals, can we have some things in common with regard to health? And the answer is no, but also yes. But this is when we get into like a much more granular sort of, question and response, to which we simply just don't have time to get into. But I think what we can all recognize is how complicated, but how promising these concepts of public health and common good are. We need to pivot in the interest of time to another set of questions. And I'd like to turn to Paul and his expertise on Mormons' health and Western history. Paul, your research has demonstrated that Mormons were clearly interested in health and medicine. Can you tell us a little bit about that? And as a follow-up question, how were members of the Church of Jesus Christ of Latter-day Saints perceived by the medical establishment in the 19th century?
Yeah, so let me talk about Latter-day Saints' vision of their own health first, and then turn to how they were perceived by outsiders. I think those are two important facets of this question. So the Latter-day Saint tradition is in itself born in a moment of health reform. The 1830s, when the religious tradition arises in upstate New York, is a moment where the nation as a whole is going through a health reform movement. There are reformers who are suggesting that grains and fruits and vegetables are good for the body. Concern over temperance, alcohol consumption is also a part of this context. And Joseph Smith, the leader of this new religious tradition, by 1833 will articulate a health code for his people, for his followers, that is grounded in this health reform movement. It articulates very similar ideas that, grains and vegetables and fruits are good for the body, that tobacco, alcohol, not good for the body, warns against hot drinks, which were later interpreted to include coffee and tea. There were concerns about those as stimulants in the 19th century. So that 19th century context helps us to understand the ways that the Latter-day Saints responded. And there is concern for the health of the community. Obviously, there are all kinds of fraught diseases in the 19th century: cholera, smallpox, malaria, and Latter-day Saints experience all of these. And there's also a class element to what's going on in the health reform movement as well. You have people like Samuel Thompson, who will look at the medical field and suggest that it's actually geared toward the upper class, but also that it has problems. And he's probably not far off in terms of some of the procedures being used in the 19th century, we know today weren't all that great for the health of individuals. And he is suggesting that herbs are a good solution, that steam and emetics are a way to expel toxins from the bodies. And there are Latter-day Saints who also become Thompsonian practitioners. And so that's one way that they're attempting to deal with the world that they are living in, and attempting to deal with the problems of disease that they face, and death is a constant threat for them. They will practice faith healing as one method of dealing with it, but also, some of them at least adhere to Thompsonian medical practices, and it's a constant concern for them. Death is always at the door. Death rates, they actually inhabit for a period a swampland. And death rates are really high when they inhabit that swampland in Nauvoo. So those are all factors that they are dealing with. Then the other part of your question was, well, how do outsiders look in on the Latter-day Saints, and how do they perceive them? And, one of the panelists has already suggested that, citizenship is one way that we have talked about public health. And so who gets to participate in, medicine that is available for the public good? And there's notions that there are people who belong and there are people who don't belong. And Latter-day Saints were defined in the 19th century as people who don't belong, who shouldn't be a part of the public health because they are actually diseased, they are deformed, they are degenerate, and should be excluded. They are even racialized as an other. And this is really a process that a variety of immigrant groups go through, and the Latter-day Saints are no different. Even if they're coming from Western and Northern Europe, even if they have blonde hair and blue eyes, they are denigrated as not white enough, as a part of a public health threat. So just a couple of examples to substantiate the claims that I'm making here. A medical doctor in 1860 is sent west as a part of Johnston's army, what comes to be called the Utah War, and observes the Latter-day Saints for a few years, and then files a report with the United States Senate in which he suggests that the Latter-day Saint practice of polygamy is in fact giving rise to a new race. And he describes this new race as degenerate, deformed, receding forehead, big lips. I mean, he's got the whole physical description, and suggests that Latter-day Saints are a racial problem for America to deal with. There's actually New Orleans medical science community gathers for a conference by the end of 1860 on the Mormon body. And all the doctors who gather together there buy Bartholow's argument and push it forward, except for one who suggests that, the Latter-day Saints have only been around for 30 years. You're going to have to study them for at least 30 more before you can argue that a new race is arising in the Great Basin. Bartholow's argument was simply that the Latter-day Saints are too successful at winning converts from Europe. Because polygamy is producing this deformed race, it will die of its own degeneracy. The next generation will become sterile and it will die out. But they are bringing in new people from Europe, and therefore will perpetuate the Mormon problem into the future. So this will lead to the Latter-day Saints being seen as an immigrant problem. And just one small example, in 1856, a New York Times reporter visited a ship of Latter-day Saint immigrants who arrived in New York and published a report and said that, well, Welsh immigrants we normally welcome, but Latter-day Saint Welsh immigrants are dirty, disgusting, and diseased. And goes through all of the immigrants on this immigrant ship to suggest that, well, if they were just the average Scotch person, then that would be okay. But these are Latter-day Saint converts. And just one small quote from this report. So the report described the Latter-day Saint immigrants as belonging to the lower almost the lowest classes of society. Their countenances were embruted with ignorance and dirt. Not the material dirt of a sea voyage, but the moral dirt of a life of imbecility and indolence. So they're going to be a drain on this concept of the common good, a drain on public health. They will be diseased and degenerate and produce undesirables amongst us. And so that's how Latter-day Saints are perceived in the 19th century, as a threat to the common good, not as reinforcing and helping to create a common good. So they're otherized. And I mean, the sad irony is that then other immigrant groups into Utah across the course of the rest of the 19th century, the same process will play out amongst them. Chinese immigrants defined as diseased, Hawaiian immigrants who are converts to the Latter-day Saint faith, even by their own fellow congregants. Well, leprosy is rumored to exist amongst them. They must be excluded and expelled. We can give them land 75 miles southwest of Salt Lake, but we don't want them living amongst us. So those fears of who fits and who doesn't fit also inform our conversation about public health.
Mm-hmm. I mean, there's so much to unpack there. One of the things that I heard that was so interesting is, in the 19th century, when we have sort of this bacteriological revolution, we have the emergence of what will become modern medicine, particularly this notion that it's actually microbiota that triggers disease. It's not, really anything else. Specifically, medicine is being positioned as being like value neutral. Medical science is value neutral. And yet what you pointed out is that religion and character and class, at least perceptions of them, play an incredibly important role in determining health, influencing health, and how we see health. And so it seems like health perceptions and perhaps later healthcare delivery itself is completely not value neutral. If medical science is value neutral, the way we talk about it, handle it, and deliver it and make it accessible is quite the opposite. And we see that already in the 19th century in the examples you cite. I was in my own research, I've looked around at the different sort of like handbills that are passed around that are making this case that the Mormon body is diseased and essentially devolved, et cetera. And one of the metaphors that they use is that the Mormon church, the LDS church, is an abscess on the body politic, and it needs to be drained, which is it's a very frightening way to put it. What exactly are they getting at? Paul, do you want to just maybe speak into that a little bit?
I think that's exactly right.
At?
Yeah, that's exactly right. I mean, the most famous example of that is Stephen Douglas. He sees the Latter-day Saints eventually as a fly in his popular sovereignty ointment. Popular sovereignty is supposed to help solve the question of slavery, but if popular sovereignty is going to be used to enable polygamy, then it's a real problem for him in this 19th century political context. And so he uses the very metaphor that you described, Ben, in one of his speeches. He describes Utah and the Mormon population as a filthy, disgusting ulcer. And his solution is to cut it out. He actually proposes obliterating Utah, dividing up, getting rid of the Organic Act that organizes Utah as a territory, dividing up the population, forming new territories to solve what was called the Mormon problem in the 19th century. And so Utah is seen as a disease on the body politic of the nation. And it really does inform our sense of, who is the public, right? And also who gets to share in what we deem the common good. And we have a long history as a nation of defining people as not worthy of participation in the common good. And there are all kinds of lines that dissect and bisect that, racial, ethnic, religious, all of those come into play in the Utah experience.
thinking more broadly about Utah as being an important state in the American West, meaning really west of the Rocky Mountains. One thing that you would be well aware of, and I think many of us are, is that in the 19th century, the American West is perceived by many as this place of abundant health. It is a place where if you're sick, you can go to get better. It becomes a destination for health seekers. I'm curious, who are these health seekers? And maybe a follow-up to that question is, would you say that people of the 19th century and in the 20th century, American health seekers, would they actually say that Utah and the West supported their physical, mental, emotional, and spiritual vitality?
Yeah, great question. So there is this notion in the 19th century, it's a part of the broader westward movement, right? That by going west, you can recover your health. The notion was, people are piling up in cities in the East. They're filthy. That seems to be where disease is located. As they're sort of developing their understanding, like you said, right? It's not until the end of the 19th century where we really start to really understand how some of these diseases are spread. And the notion is, the squalor of Eastern cities is a part of the problem. Unhealthy air is a part of the problem, or living near swampland is a part of the problem. And the West seems to be a part of the solution. And 19th century journals bear this out. Those who are moving west talk about the health of the country. They talk about healthy locations. They talk about mountain air, which will restore your health. Locations away from swamplands. Fresh water is a part of this. And the West is seen as a part of the solution. The problem is, if you really follow this, then you have people who move west, they develop urban centers, and you have also disease locations or locations that become ripe for the same kind of diseases that were, being passed around in those urban locations in the East. But nonetheless, the West was seen as a part of a place where you could go to recover your health. Your question was, well, who are these people? And that once again gets at the class aspect of public health, because if you could afford to travel west to recover your health, that means you were a part of, at least the middle or upper class. So you could afford to do this. So you're leaving out a segment of the population who might not be able to escape the unhealthy conditions in which they live. And so you have travelers who do come west seeking to recover their health, and some of them will report that they're successful, that the mountain air, whatever else it may be, has helped them. Those who come to Salt Lake, steam baths. There were the steam pools in what's current North Salt Lake that they would visit. These were seen as helping to release the body of toxins. Or the Great Salt Lake and its mineral bath, a place to visit and potentially recover your health. Or simply the dry climate and the dry mountain air. All of these were seen as a part of solutions to poor health. And you have people like Thomas Kane, who was an influential friend of the Latter-day Saints, but sometimes suffered from poor health. And he would take trips to the West as a part of his effort of recovering his health. So there's a class element to the ability to attempt to do so. And then you have, like I said, city locations or mining locations where you have Chinese immigrants who come, and they are seen as a threat. So you're still in the West, but if Chinese immigrants are living in these mining camps, their laundry facilities or their participation in the mining camps in the West are seen as disease-ridden, opium dens, and a threat to the health of the broader community. And so sometimes there are fires in various Chinatowns in Utah, in Silver Reef in southern Utah, for example. Never really proven, but the assumption was it's set by arsonists to drive the Chinese population out of the mining camp because they are a threat to the stability of the whole.
Mm-hmm.
So,
Yeah.
the West might be a place for recovering public health, but there's still these dividing lines in terms of race and ethnicity and what public health looks like in those settings.
It is telling that the national parks, the very first, several of them, the first three, all emerge in the American West. And there's various ways to interpret that, but let's just think about them. They're Yellowstone, they're Yosemite, they're Glacier National Park. And I think it does, that fact alone, I think, does provoke the question, is the West exceptional? Is the West a special place with regard to, public and personal health and human flourishing? The philosophy of parks, of course, go long back, even to Roman times. The idea that these are places where people can dream, they can think, they can relax, and all of these things are conducive, or at least examples of human flourishing and human health, perhaps the common good. Whoa, hang on! I never get a phone call. Just 1 second. Okay, that was fun. So so the West on the one hand is sort of the safety valve. It holds the possibility of promoting human health, and yet at the same time, it's no longer a safety valve to some folks. If you look at these cities, particularly Salt Lake City and other places like Denver and Los Angeles, they become these places where a new wave of immigrants will come and settle, and they are seeking opportunity, as immigrants often do. Something like 11 million immigrants from Southern and Eastern Europe come to the United States in the late 19th century. A huge number will come to Western cities, particularly folks coming from Poland, from Russia, from Greece, from Italy, will settle in Salt Lake City. Another million from China, Japan, and Latin America will come to Salt Lake City, and throughout Utah and the broader West. And their experience of the West as a destination of health and financial, not just survival, but even thriving, is complicated by the reality that they actually experience. Paul, you said that cities very quickly become so densely populated that they actually become a threat to personal hygiene and personal sanitation. And I would like to share my screen and actually illustrate this very truth as it plays out in Salt Lake City. Okay, so in the late 1890s, Salt Lake City is a very different place than it was in, let's say, the 1850s. The population is much larger. It's much more culturally and ethnically diverse. It's stratified by class. The population is increasingly working in urban industrial jobs as opposed to rural agricultural jobs. And the primarily the industry that is employing so many folks, particularly immigrants, is on this side of the city. So if you can see my pointer, I'm making this broad circle. So Main Street just runs right through the center of this map. And then what becomes known as the West Side is essentially west of Main Street, west of downtown, west of the Central Business District. And of course, on the east side here, you have the East Bench, where the University of Utah currently is, and then the Avenues District, which is sort of the sloping hill. And what a lot of these immigrants, but also Native Utahns, Native Americans experience in real time is the problem of urban densities without public health measures in place. So in one sort of famous case study, the central business district experiences all these waterborne bacteriological infections because of polluted well water coming down from City Creek, which would then provide water for some of these shallow wells, and people who are doing business down there are getting sick. And so there is this call by the city council and the Chamber of Commerce to actually source fresh, cleaner, more pure water. And there's a number of ways they go about doing this, but one thing in particular that they do, and the central business district will pay for it, is they'll create these basically these gigantic holding towers for pure water in Parley's Canyon and up on East Bench, and that water will be provided for by the local mountains, and then through these redwood and then later cast iron conduits, it'll be piped down to the central business district and to the avenues. And so it's in those places where fresh, pure, I guess, less contaminated water will be provided. Well, as it happens is that while they might have this fresh and pure water, the increase of water access leads to literally the overflowing of not just their wells, but also their privies. And so when their privies overflow based on the gravity of the valley floor here, it, like, all that effluent begins to drain to the lowest point. And the lowest point is the west side, where you have heavy industry, but you also have a lot of immigrant neighborhoods. And so the immediate upshot is what is good for this side over here, fresh and pure water in abundance of it, actually leads to a major sanitary problem on this side. Well, what's interesting is that the question then becomes, well, if overflowing privies are a problem, we need to create a modern sewer system in which all this effluent is channeled through a modern sewer, and then it's taken out of town. Well, I think the reasonable thing to do would be to provide a modern sewer system for the entire valley floor, for the entire city. But because of a lack of a municipal bond market, only people who could pay for modern sewer hookups actually got access for it. And so what that meant is that the folks, basically this middle and upper class progressive set of the avenues in the East Bench, they could pay for these sewer mains. And what you can see here is a map by the Journal of the Association of Engineering Societies. And what you see here is the sewer system of Salt Lake City by 1909. And this one line here is the gravity sewer, which simply means the very first sewer whose effluent was pumped by gravity, not by a diesel engine or some other power source. Well, people who lived east of the gravity sewer were fine because their effluent was taken away by this modern sanitary technology. People west of the gravity outlet sewer faced a major problem because they were still essentially drinking well water that was contaminated by their own backyard privies. And so I guess the point that I'm trying to make here is when we talk about public health developments, public health technology, it might be funded actually by private interests and it goes to private concerns. It doesn't necessarily go to public interests and public concerns. And so public health is a real misnomer at this point in time. We could go on and on about sort of the inequity with regard to public health programs that emerged in Salt Lake City in the early 20th century. We could talk about how that plays out in modern hospitals, Holy Cross, Deseret Hospital, St. Mark's in the early 1910s and 1920s. We simply don't have time for it. And I'd like to pivot to another set of issues. Len and Monique, you're both very interested and have specialization in the contemporary social determinants of health. My question, I think, for Len first, and then Monique, you can follow up. My first question is, what, in your opinion, are the most important social determinants of health today? Are they various? Do they include income? Do they include geography? Gender and sexuality, race and ethnicity. Can you comment on this?
Thank you so much, Ben. Yes, definitely. That's actually a difficult question to answer, primarily because there are so many influences around us. And I like this quote from, it's a Native American quote that says, "Humankind has not woven the web of life. We are but one thread in it. Whatever we do to the web, we do to ourselves. All things are bound together, all things connect." And that was Chief Seattle. So is there one important social determinant of health? I don't think so. I think every determinant of health influences another. So what you do to X actually results into Y or Z, and so on and so forth. And that's why it's hard to just pick one and say, this is the causes of the causes. And I'll go into that later, but I'll have Gretchen actually, weigh in as well.
Mm-hmm.
I'm going to toss this to Monique because I know that you know much more about social determinants of health and are ready to speak on that. So I'm going to toss it to you.
No problem. Yeah, I mean, I'm right with Len. There are so many different factors, but if I had to pull out a few and talk about a few of the big social determinants of health, the ones that often rise to the top in the research are education. So health indicators that we look for regarding education is on-time high school graduation rates. So that can be a huge indicator for a person's health outcomes over a lifetime. Income, of course, that makes a lot of sense. There are so many things connected with income in regards to health insurance, having abilities to have transportation to your access to care, being able to provide healthy food, to be able to live in an area where you're not in a food desert, which is where there's a lack of healthy or comprehensive food options. So income really plays a huge role. But Ben, you mentioned geography, definitely, and that ties in a whole bunch of social determinants of health. A quote that I love to use from a physician who is big in the upstream movement in LA, his name is Dr. Rishi Manchanda. He says, your zip code matters much more than your genetic code. And that's what we continue to see, is that our genetics, our biology, our healthcare services play a very small role actually in health outcomes throughout the lifetime. So much support for that.
That's a great little pithy line. Your zip code is actually more important.
Yeah.
Right.
So, yeah.
And it seems like that was the case in that particular sewage example, right? Like where you live really did disproportionately determine if you were going to get these public health resources.
Yes.
And if you got them, you're doing fine. But if you did not get them, you were behind the 8 ball. Yeah. And so yes, where you live really matters. I guess a follow-up question is, this is an honest question. Would either you, Lan or Monique, say that there are social determinants of health that seem to be somewhat unique to Utah and the West, or would you say that they basically are generally shared across the country?
Actually, I think in many ways, it's the confluence of that social context that produces what we have currently in Utah. And maybe this might be a great segue to actually show my slides, Ben, just to kind of discuss, social determinants of health here.
Mm-hmm.
Okay, so I know we have always kind of, talked about social determinants of health. When I was first doing this research about 11 years ago, it was kind of a mouthful, and it was so hard to actually translate social determinants of health to the local level and also aim for a common definition or a shared definition. But this is the classic one from the World Health Organization. So when we talk of social determinants of health, we're really talking of conditions where people are born, grow, live, work, and age, including the health system. So this is not exclusive of the health system, but includes it, and it is shaped by the distribution of money, power, and resources at global, national, and local levels. So it is important because it is responsible for health inequities, which are defined as the unfair and avoidable differences in health status seen within and between countries. So going beyond that mouthful of social determinants of health, I would just like to actually focus on 4 words here. So when we talk of social determinants, we really are talking about conditions where we are. And we're also talking of of how these conditions are actually shaped by distribution of money, power, and resources, and how this has resulted in those avoidable and unfair inequities in health outcomes. So those are really the 4 words that we should really think about when we are talking of social determinants of health. And Ben and Monique actually alluded to this as well. Why are this important? Well, these are important because we don't necessarily have to just stop at the biology of a disease, at its pathophysiology, but we need to look at conditions in which people are empowered to be able to make healthy choices and to follow a path of a healthier lifestyle. This one actually is from the Kaiser Family Foundation. And what you can see here is that healthcare only contributes 10% to well-being. Genetics is 30%. But if you look at both individual behavior and social environmental factors, that's 60% of an individual's health and well-being. And this is why social determinants of health are so important, because we need to move beyond disease control to addressing the root causes. And this is a very classic conceptual model of the social determinants of health coming from the World Health Organization. And this is from the report by Sir Michael Marmot, Closing the Gap. And it's showing us here a variety of factors that could be categorized into both structural and intermediary determinants. The structural determinants are the socio-economic and political context, as well as your socioeconomic position. I was listening to Ben and Paul talk about class, religion, Monique referring to education, and Paul again going back to race and ethnicity. This determines where we are in the socioeconomic ladder, which then impact pretty much, our material circumstances, our behavior, biological factors, and even psychosocial factors. So these are those intermediary ones which eventually impact health and well-being. Again, from the Kaiser Family Foundation, this is looking at all of those factors around us in our macro system: economic stability, neighborhood, physical environment, education, food, community safety and social context, and healthcare system. And this is how racism and discrimination, for instance, how will that eventually impact all of these various sectors, and how these inequities created can impact, for example, life expectancy. So Ben actually alluded to the Mountain West as well as parks and being conducive to health. I mean, let's look at Utah. Let's focus on Utah, highlight Utah. And this came from the Department of Tourism in Utah. If you look at Utah, these are the numbers. Wow. We have so many state parks, 43, 7 national monuments, 1 national historic site, 2 recreational areas, 5 national parks. And if we go beyond Utah's topography and geology, we will find out that it's actually one of the healthiest states in the nation. And this is based on America's health rankings done by the United Health Foundation for 30 years. It's going on its 31st year. And if you look at the state of Utah, not only is it abounding in parks, but it's also one of the healthiest states in the nation for, twice in a row. Okay, well, not in a row, but twice at least. It was 7th in the nation in terms of health. It was 6th 3 times. It was 5th 6 times. The 4th healthiest state in the nation 4 times. 3 times the healthiest state in the nation. 4 times the 2nd healthiest state in the nation. And look at this. It's 7 times the healthiest state in the nation since the time that United Health Foundation started America's Health Rankings based on several metrics that focus on clinical care, physical environment, behavior, as well as socioeconomic status, as well as equities or inequities in socioeconomic status. But this is a wonderful way of saying that this description of Utah's life elevated is truly literal. Not only is Utah built on a solid foundation of rock with mesas and also with varying cliffs, mountains, but truly it's life elevated. So it's actually, one of the best states for raising families. It's great with outdoor recreational activities, and it's strong, bold, and rising up from solid footings, if I were to borrow the words of Utah's Department of Tourism. But if you actually dissect Utah, and I know I love that Ben highlighted Salt Lake Valley and its sewage system. Well, this is no longer Pioneer Times Salt Lake Valley, but this is Salt Lake Valley now. So let me take you to at least 4 different places in Salt Lake Valley if you haven't been here before. Let's start, with the avenues in the foothill area. So these are the areas very close. If you have seen the U on the mountain, that's where you will find the avenues and the foothills. And then just about 10 minutes by car, of course, depending on traffic, you are going to go to downtown Salt Lake, 3.5 miles away. And then another 8-minute drive by car would be South Salt Lake. And then close to the middle of the valley would be Sandy Civic Center. Why am I highlighting this? We know that Utah is life elevated, right? Very healthy state. But if you look at life expectancies, which is pretty much an epidemiologic measure that gauges the overall health of the community, and it's otherwise defined as the expected average number of years of life for an individual born in a certain population. In the avenues, you can live as long as 87 years. That's the best, not only in the state, but also the best in the world. But again, 3.5 miles away, downtown Salt Lake, guess what happens? Wow, an 11-year difference with regard to life expectancy, 76 years. Go another 3 miles south. Wow, that also goes down, further, 73.8 years. 73, 74, we're talking of life expectancies seen in developing nations, like, for example, El Salvador, Bahamas, Belarus, Dominican Republic, West Bank and Gaza. We're not in West Bank or Gaza. We're not in Honduras, right? We are in Salt Lake. We are right in the middle of one of the healthiest states in the nation that has never even been ranked outside the top 10. Look at Sandy Civic Center. It's up again. And yet they are not geographically distant from each other. I love this visualization of social determinants of health differences or disparities in terms of riding UTA's track system. So we have a train system that goes, along I-15, and each stop actually corresponds to small communities. Let me just take you here. Based on the IBIS data, which is the information-based indicator system from the Department of Health of Utah, so US life expectancy is 78.7. Utah is even a year higher. Okay, remember where we were in the avenues, close to 87 years of life expectancy, and those zip codes. Remember what Dr. Risi Machanda said about zip codes and genetic codes? So avenues is almost 87, foothills is 85.3, but go to the next train stop of UTA track system, downtown Salt Lake, it goes down to 75.9. And these are the corresponding zip codes that are covered by such a reduction in life expectancy. And then go down another 3 miles, South Salt Lake goes down to 73.8. The red ones here are those that I have colored red because they are lower than that of Utah's life expectancy. And we're talking here of a 5-year life expectancy from 2015 to 2019. So a very good summary of how each community is doing. But then go to the next train stop, Mill Creek and Holiday. Wow, we're back into the 80s. 84 is about, how long people in Japan lives. Then it goes down to 78.5 in Mary. Do you remember that sewage system map that was shown by Ben? Let's go to the west side of Salt Lake. I have not seen here, not that there's an association between the sewage system now and the sewage system during pioneer times, but you can see for some reason the west side, has this life expectancies that are far shorter than that of the state of Utah itself. That's the overall life expectancy. Is it any different if you go down south? If you continue your UTA track strain ride down south? Oh my goodness, the epidemiologic story stays the same. From Taylorsville, Midvale, down to Sandy Center, where you actually hear pretty much the voice on the train saying, you have reached the end of the line if you're riding the blue line, okay? So that's a Sandy Civic Center. So we have here pretty much, several life expectancies that are even higher than that of the state's overall life expectancy. Again, go to the west side, you see a lowering of life expectancy. So the question is, what is happening here? And again, of course, just like what Dr. Visi Manchanda said and Dr. Frieden, former CDC director, said, this is about where you live. It's location, location, location. It's more than your genetic code now that's influencing your health, but actually your zip code. And I'd like to stop at that point there, just to give us, kind of just to whet our appetite on how Utah is doing right now. Is it unique to Utah? I think in many ways it is. The confluence of class, of religion, of education, of material resources, and basically how we organize our affairs in society, that influences Utah's social determinants of health.
Thank you so much, Len. You point out a number of really striking things. Western historians might bristle at this, but what you're pointing out is that the West is special. Utah is special. Utah is exceptionally special in so many ways, in particular with regard to life expectancy and just overall, human health. And yet you're also saying that, it's like history has not elapsed us. History is not even past. History, frankly, continues to inform the present, particularly as it plays out. And, if you're, east of the 15 or west of the 15, essentially what you're talking about is a variation on a theme of, some research that I and other scholars have done about, Salt Lake City's health profile in the early 20th century. Maybe this is a nice time to pivot to our final set of questions and talking points, and that has to do with how we teach healthcare, how we teach, aspiring clinicians to think about the human body and the human mind and basically human flourishing. And I want to turn in particular to Gretchen, and then maybe Monique and Len can participate in this conversation as well. Gretchen, you're interested in healthcare education, delivery, and the greater good. Can you tell us a little bit in particular about your particular field of studies? It sounded like you're interested in an interdisciplinary field called the healthcare humanities.
So yes, so you might have heard of it before as the medical humanities, the healthcare humanities, health arts and humanities, health humanities. There are a lot of names for the same thing. Health humanities or healthcare humanities is most often used because it is more inclusive than saying something like medical humanities, which sometimes sounds like only doctors, and it's important to all the other healthcare specialties that they're included as well. Yes, so I'm an arts and humanities scholar who is a full-time faculty member at the School of Medicine. That might sound unusual, but most medical schools and many other healthcare, health sciences campuses have someone like me or many people like me. The idea behind it is that the arts and humanities are absolutely a part of any kind of healthcare education, any medical education. The way I often explain it to my students is you need that basis of science. You have to understand the scientific workings of the body, the way that drugs work, the way that medicine works. You absolutely have to have clinical skills. You need to be able to know how to lay hands on someone, how to work the machinery, how to actually do the care. But there are all these layers on top of it that are about the human experience. So if you don't have the skills, the context, and the understanding to deliver what you know and what you can do to the person in front of you, then you're not a human delivering care to the human. And what the humanities do is they really investigate, illuminate, elucidate what it is to be human. And this is not a one-way street, right? So when I teach humanities, when I talk about humanities, I'm talking about the whole human experience and not just the human in front of you as a patient, but you as a human as well. Where health humanities came from, people put different timelines on it, really started picking up in the 1970s and 1980s. The need for it came even earlier. Way back in the beginning of the 20th century, there was a move with the Flexner report, which I won't go into, but it was a move to standardize medical schools across the US, make sure they were all teaching the same thing. Turned out they were not. And so what Flexner focused on in large part was making sure they were teaching all the same science. They were all at least getting the same science and clinical skills. Flexner and medical school deans at the time assumed everyone going into medical school, of course, had exposure to the arts and humanities, of course was going to the opera, of course had a classical education, of course was playing music. And so that didn't need to be included in a medical curriculum because it was part of everyday life. Now we know that's only true for an elite group of people in the early 20th century, but those were the only ones going to medical school by and large. So as we move towards the middle of the 20th century and then on towards later 20th century, there's this understanding that something has been lost. Right? We're focusing so heavily on science and clinical skills that we're forgetting that medicine is ultimately humans giving care to other humans. And I should be saying healthcare, not just medicine. And so there was a move back to say, well, what have we lost when the arts and humanities kind of got pushed aside in this medical school curriculum and training that emphasizes so much science and clinical skills that there's no time for anything else. And that's where the health humanities started to rise and say, how are we still helpful? How can we still give context? And what do we do? It's not just that the humanities is supporting healthcare. The humanities is an integral part of it because it is about what is the human experience? What is health? Why are we even giving healthcare in the first place, right? So it's not just here we can illustrate or we can add to your science and clinical learning. It's why are you doing this in the first place? What does this all mean? So that's the health humanities in my very, very short condensed speech.
So yeah, Gretchen, can you provide, and maybe Monique and Len, if you want to jump in here, can you provide maybe some concrete examples about of how the humanities really help doctors and patients in clinical decision making?
I have one right on the top of my tongue that's about history. So I teach, as you noted, I'm very interdisciplinary. So I teach and incorporate everything from the arts and humanities across the board. But when we teach our first year students about vaccines, we also teach about vaccine hesitancy, vaccine refusal, vaccine caution. And one of the ways that we teach about it is through history and reminding them that what we are seeing now is unique, is special for the moment, but it's not that it's never happened before. As long as we have had inoculations and vaccines, and honestly, any medical intervention of any kind, there have been people who are cautious, concerned, against it, and those reasons vary. And so looking at the history of vaccine refusal and understanding that, yes, we are facing something we've never faced before, where people are refusing or cautious or concerned or all the ways you can describe that. There is a specific set of circumstances right now that are making people feel the way they do about vaccines. And that would include being pro-vaccine, right? Being really ready to go get it. But it's always a discussion that has to be done in historical context and say, why now? Why this feeling? And then it has to be individualized again. So you cannot say to one person who is cautious or hesitant the same thing you might say to another one if you want to have an ongoing healthcare relationship with them and convince them about the things that might be best for their health, or maybe they convince you about what might be best for their health. But the historical context is one of the most helpful things to understand students, that it's not just right now I have the answer and I have to get it to this person, or it's me against them. It's, wow, we're part of this historical continuum of people trying to understand their bodies and the medical interventions on them. And that shifts according to historical and social context. So I have to be aware of that historical and social context if I'm going to give the best, most appropriate care to the person in front of me right now in this historical moment.
Mm-hmm.
Yeah, I'll just jump in. That's so well said, Gretchen. I was going to also provide examples of using history and historical context. It just really, provide such a stronger foundation for students. Same thing when we have talked a lot about the flu pandemic of 1918. And, I was just the other day in class showing students pictures of outdoor classrooms that were, I have a picture of New York City elementary school kids having an outdoor class on the deck of a boat. And yet here in our university, we had outdoor classrooms last year in a parking garage, and we thought we were innovative, and it was, but yet we can learn from the past about how to do this. I talk about how we had fights about masks 100 years ago. We're still fighting about them today. And what can we learn from those situations? We've talked recently about Typhoid Mary, who was a case in the 20th century who had asymptomatic typhoid, kept spreading it and got put in a quarantine hospital for the majority of her adult life. And we can look back on that now and say that was a horrible thing that we did to protect the common good, if you will, or the health of a society. And so it just helps us talk more in depth about that constant tension that we experience in public health between the collective good and individual liberties. And how do we find a balance in that, which we're obviously struggling with today as a society.
Mm-hmm.
Hey, thanks, Monique. That was really great. And Gretchen, I love how you brought both the humanities and the art in the application of medicine. I mean, that's like going back to when I mentioned about the definition of public health that I love from Charles Edward Emery Winslow, that public health is not just a science, it's also an art. So how can we use, say, this humanities in health? So the problem right now that I see is that there's a disciplinary overemphasis on the biomedical aspect than on the motivations behind our behavioral intent. I mean, going back to the Kaiser Family Foundation factors on health, 10% is only provided by healthcare, 30% genetics, 60% behavior, and then environmental influence. I mean, no matter how important technical expertise is, it is also important to understand how behavior and motivations impact health. So when I am teaching my class, so I teach a class on chronic diseases as well as health determinants and disease, I always emphasize to my students, the value of the human dimension of disease. We're not just talking here of COVID-19, we're not just talking here about pneumonia or a specific organ, we're talking of the whole person. And there is also power in using storytelling to connect with patients, allowing patients to express themselves while you, as the practitioner or provider, listens, and then being able to, at the same time, express ourselves so that our patients know that it's okay, that stories of pain can be shared, and that you provide them that psychological safety so that patients know that their stories matter. Just by mere storytelling, that's a humanities approach. That's breaking down those differentials inherent pretty much in the practice of the profession.
Mm-hmm. Every now and again, I'll speak to nursing students and, encourage them to think of their clinical work, in this way. Certainly, your calling, your vocational goals are to make sure that your patient's blood pressure is right, that you can administer vaccines correctly and efficiently, et cetera. But also remember that, a lot of the folks that you're going to be seeing in the clinics are suffering with like major life trauma. They might have lost a loved one. They might themselves be facing a medical crisis that they didn't anticipate. These people need comfort, they need wisdom, and frankly, you're not going to get that out of a strictly technical type of education. And it's really the humanities and in its various disciplines that provide all of that sort of knowledge and wisdom to comfort them with. The name escapes me, but a pretty well-known epidemiologist at Harvard Medical School raised the following question, and it really has to do about how we teach in medical school today. Why do we know so much more about the determinants of cardiovascular disease than we know about the determinants of what gives rise to a sense of purpose of life? And that really does get at sort of, I think, the narrowing of the medical school curriculum that many of you have alluded to. Molly Worthen, some of you might know the name. She's a columnist for the New York Times, and she writes on higher education. And she had a really interesting article that she put out a couple months ago, and I'm going to share it real quickly, at least part of it. I'm just going to go ahead and read this quotation that I redacted. It's worth noting that the most famous doctor in COVID-era America is a committed humanist. Anthony Fauci, director of the National Institute of Allergy and Infectious Diseases, fell in love with the humanities in high school and majored in classics at the College of the Holy Cross in Massachusetts. When he pondered life after college, he reflected there was this tension. Would it be humanities and classics, or would it be science? He told the New Yorker last year. And as I analyzed that, it seemed to me that being a physician was the perfect melding of both of those aspirations. As these humanist MDs well know, history, literature, and philosophy aren't just good training grounds for an empathetic bedside manner. They shed light on the big questions of healing and suffering. But it's hard to make the pitch that humanists have something meaningful to say about big questions when so many of us have fallen prey to ever narrow research interests and make no time for general exploration of the world.
Ben, could I just add to something you said, which was a lot about physicians in particular and healthcare providers providing comfort.
Mm-hmm.
And I would say that the humanities also teach us to think about what the person in front of the provider is providing, and that it is not a one-way, I give to you. And so, in fact, some people don't like the phrase healthcare providers because it sounds one way, acting on a passive person. And that part of what the humanities can teach us and the arts can teach us is that it's about two humans truly interacting, and that they are bringing something to the interaction just as much as the healthcare provider is. And some of the best physicians and providers, and Monique, you might know this, will say that the person in front of you will tell you what's wrong with them. They have so much information, and part of what you are doing is helping them understand the information that they have brought with them in their bodies and their words. So I think that's a large part of what Dr. Fauci is actually talking about too, is how much of medicine is not just about science, but it's about what is this interaction? What is this culture of medicine? What is this interaction within a culture of medicine? What does that mean for both of these people, and not just one active and one passive agent? And that's something I feel very passionately about. And that's why I wanted to add it, because I don't ever want the arts and humanities and even history to be seen as something that adds to this kind of putting medicine or healthcare on someone. I want it to actually pull us back away from that kind of mechanistic view and say, it's about a human interaction, about getting to health, getting to common good, getting to what we are as a body individually and a body politic.
Mm-hmm. Thank you. We are very close to our time to end, but what I'd like to do is leave just a few minutes for Q&A. And I think our hosts, Holly George and Jedediah Rogers, are curating some questions. Jedediah, are you ready for us?
Yeah, we are. We've received, and Ben, you can probably see these as well. I'm happy to read some of them out. We have questions from a couple of individuals. Kevin Johnson has made a couple of comments, and one related to something that you just addressed, Ben. And let me read this one. He's actually addressing this to Gretchen. He says, what you're describing is still not happening enough prior prior to beginning medical education, we still tend to emphasize the sciences. As a result, the powers that be who decide who gets into medical school still seem to be more concerned about the sciences than the humanities. As a result, some people who become medical providers are still not very good at being people. And so, Gretchen, I don't know if you want to comment on that.
Of course I do. I think the operative words there is it's not happening enough. It is happening, and I can give you some really great things that have happened in the past couple of years. One is that the National Academy of Sciences, Engineering and Medicine, and the AAMC, which is the Association of American Medical Colleges, released a joint report on the importance of arts and humanities in medical education. And they were speaking specifically about medical education, but they emphasize that. And it's a public paper, it's a white paper. You can go, it's called the Frame Report, FRAHME. You can go find that online easily. But part of what they address is how are we preparing students for a life in medicine that includes the arts and humanities? How are we admitting students? So putting admissions committees on task as well. There are also a great number of pre-health humanities curriculum. I think we're up to like 30, somewhere in the 30s in the United States, where you can be an undergraduate. So before you enter any of the health sciences, and you can major, minor, or concentrate in some version of the health humanities. Those have become incredibly popular and are popping up all over the US. There are also some moves to slightly, I don't want to say devalue, but de-emphasize things like the MCAT and standardized board exams. And in fact, our major board exam in medical school just went to pass-fail, so that there is more time in the curriculum for things like the arts and humanities that are harder to put on a standardized exam and therefore get ignored in standard curriculums. So this is all to say you're absolutely right. I would agree with you. There's not enough. There may never be enough, but we are seeing a huge turn and kind of a national turn to attention to the arts and humanities as part of healthcare curriculum, both during the training years and before you even enter a health sciences career.
Great.
Ed, I'd like to actually jump in on that response, and it's a great response. So from the time that I've started my research in social determinants of health 11 years ago, I've also looked into the medical curriculum. How much are future physicians being taught about the social determinants of health? At that time, zero. But things have actually changed right now, and many more things are starting to change. Part of the MCAT now is asking about the social determinants of health. It's asking about the social sciences. It's asking about the humanities. However, I think there is still a gap that needs to be narrowed in how we actually educate our future physicians. I actually love the work of Tadros and Ogi Ogas. It's the Dark Horse Project at the Harvard Graduate School of Education. One of the things that we have been focusing on as well in our general education system, not only in medicine per se, but in our general education itself, in that I think we're doing it backwards. So we try to achieve success by pursuing fulfillment and using averages rather than the other way around, which is getting better at the things that we care about the most. When we teach doctors, we're not teaching them to be wonderful doctors, people doctors. We're teaching them to be so good in the pathophysiology, which there's nothing wrong about that. We need that part. But we actually fail to teach them how it is to relate to a human being who is in pain and who needs help. Maybe teaching our doctors to look into the fit, their fit in terms of what they care most about, rather than just averaging them out to be the better, to just be like the others, but a better version of themselves.
With your permission, I'll go on with another question. And just to Kevin Johnson, I will pass all of your comments on to the presenters. Unfortunately, we don't have time for all of them right now, so I'm going to pivot to a question from Fanny. She says, "This is a great conversation. Thank you. can you please cover some historical facts about the presence of alcohol as an element of colonization in Native American communities and how this still affects this group in our community? That is a good point. I don't think that we address Native American health outcomes and communities in this discussion. Would anyone like to tackle that question? Maybe Ben or Paul?
Yeah, I'll just jump in. So my research dealt with Southern Paiute in the last half of the 19th century, and certainly alcohol was a component of the colonization. I looked at Latter-day Saint settlers and Southern Paiute as well as silver miners, and obviously the sources that are available to a historian come from both the Latter-day Saint and the silver miners. We don't have the perspective of the Southern Paiute, but one stereotype that develops is, especially in the mining community of Pioche in southern Nevada, is a stereotype of the Southern Paiute as drunken and lazy by the end of the 19th century. And that's just a byproduct of this colonization. So I think you're absolutely right. Some of the encounters that, the Euro-American colonizers will have with Southern Paiute by that point is just on the streets of Pioche, a 19th century mining boomtown. And they might be wage laborers in the mines, but they're being encountered by these Euro-American colonizers as people who are, in the saloons or asleep on the streets because they have fallen asleep drunk. And those are the reports that show up in the newspapers. So very much a part of public health of, for Native American peoples, definitely is the intersection with alcohol. We frequently talk about the diseases that they encountered because they didn't have the Euro-American immunities. But I think that the question is right on target, and it leads to disparities in public health outcomes for Native Americans.
Thanks, Paul. I know that we are out of time. Let me just ask this one last question that comes from David Lewis. And if you have a quick response, that would be great. And then Ben, you can close out. David Lewis asks, does the 19th century Mormon tradition of faith, spiritual healing, anointing, blessing, prayer, and Thompsonian herbalism continue to influence responses to modern health and even the current pandemic in Utah and the West? And he writes, my question is more broadly about religious determinants on health, values, responses across the United States.
So I'll just jump in. I think there's probably some connection. It might be difficult to draw a straight line from the 19th century and those practices to the 20th because there are a lot of variables in between. And obviously, Latter-day Saints embrace modern medicine. They'll participate in, modern medicine, but you still have adherence to notions of faith healing. Some reports that we've seen, for example, in the Salt Lake Tribune, talk about people who are simply saying, they prayed about it, they're not going to get the vaccine. They'll rely upon, their faith or their notions of God saving them. Those things are still a factor. I would suggest that perhaps in terms of the way that it intersects with politics in the state, that a more direct influence would be some of the politics of Latter-day Saint leaders in the 1980s, such as Ezra Taft Benson, more directly influencing some of the context that we see play out in Utah today than perhaps, Thompsonian medical practices from the 19th century. I think there are intervening contexts, in other words, that might better inform some of what we see playing out in Utah today.
Okay. And again, my apologies to Kevin Johnson for not being able to get to all of your questions. I'll make sure that all the panelists see them so that they can see what you've written. Kevin Johnson apparently is a practicing primary care physician, has been for 36 years. So thanks for these questions. Ben, is there any closing words on your part?
Well, I just want to say thank you to everybody who tuned in. I would like to thank the panelists for participating. This has been a really fun conversation. I think it's been a very timely one. We began with trying to parse out the various meanings of public health and the common good, and hopefully we've begun to do that a little bit more in a Utah context. I want to thank Jedediah and the rest of the Utah Historical Society for sponsoring this plenary discussion and for the conference as a whole. I do think that there is some risk involved in tackling such an interdisciplinary topic by a historical association, but kudos to you for doing this. I think one of the things that we've all taken away from this conversation is that, frankly, the pandemic is an interdisciplinary problem. It's not simply a biomedical one. And so, yes, historians have every right, if I could use that word, to weigh into this very important conversation. And I think, looking forward, if in fact the CDC is correct in predicting that COVID-19 is going to remain with us, it's here forever. And if it is, frankly, an interdisciplinary problem, then liberal education needs to remain with us for the immediate future as well. So thank you all. And I hope you have a wonderful day. I hope you enjoy the rest of the conference. Thank you.
Thank you so much, Ben and the other panelists, on behalf of myself and Holly George and the other the rest of the planning team for the conference. This has been great. So thank you so much for your participation. And thanks to those of you who have tuned in.
Thank you.